Hello, everyone. Welcome to this ISG webinar. The webinar is going to be very exciting. We're going to talk about symptoms reception and final diagnostics into the complex issue of bleeding disorders, which is a major clinical problem. I'm Professor Tommaso Simoncini. I work in Pisa at the University of Pisa, where I'm head of obstetrics and gynecology, and I'm the Secretary General of the International Society of Gynecological Endocrinology. So for me, it's really a honor to be the chair of this session and to introduce the two excellent speakers, Professor Qinjie Tian and Professor Stephen Goldstein. I'd like to thank Abbott because this webinar has been supported by Abbott with a non-restricted educational grant. As you understand, this is not influencing the contents of the symposium or the presentation that, of course, is provided by two great experts in this field. So without any further delay, let me introduce the two speakers, Professor Qinjie Tian from China and Professor Stephen Goldstein from the United States. Professor Tian will talk about the clinical assessment of bleeding disorders, and then Professor Goldstein will follow up talking about ultrasound and hysteroscopic evaluation. And I'm sure it's going to be a very nice story. The two presentations will complement each other nicely. So shall me remind you to use the chat in order to think or propose questions so that we can have a Q&A session at the end of the webinars. So it's my pleasure to give the word to Professor Tian. So Professor Tian, if you want to share your slides and start your presentation, and then we will follow up with Professor Goldstein later.
Okay, okay. Thanks for the introduction, Professor Tommaso. I'll share my slides first. Okay, can you see my slides?
Yes, we see them clearly.
Okay. Hello, dear friends and colleagues. I'm honored to begin the first lectures of the clinical assessment of this series, that is from symptoms perception to final diagnostic. What can be done to optimize the patient's care? As we know, the abdominal uterine bleeding is not only a symptom of various diseases, such as palm corns, but also a distinct disorder that significantly impacts women's health. AOBO is the most prevalent cause of AOB and is associated with anovulation, oligo-ovulation, and luteal phase deficiency caused by the disruptions in the balance or immaturity of hypothalamic pituitary ovarian axis. It manifests highly variable bleeding patterns, unpredictable timings, amenorrheas, oligomenorrheas, or heavy menstrual bleeding. For example, a 20-year girl came to the clinics for irregular AOB for 20 days with symptoms of palpitation and fatigue. What should we do to manage this case? The part one, the medical history. Conducting a thorough medical history inquiry is essential for prompt exclude other potential causes of abdominal uterine bleedings and provide basement for the accurately diagnosis of AOBO. When evaluating abdominal uterine bleeding, it is important to consider the patient's age, sexual history, and the contraceptive method in order to rule out pregnancy or puerperal-related disease. The causes of AOB vary depends on the age group, with AOBO and AOBC being common in adolescents, and AOBO and PALM being common during the perimenopause. To assess the problem quickly, comparing present AOB with past regular menstrual cycles can be helpful for examining the regularity, frequency, duration, and volume of mens. Additionally, if there is intermenstrual bleeding, attention should be paid to whether the bleeding is regular or irregular, as well as pre or post-menorrhea occurrence and any accompanying symptom, such as breast tenderness or increased leukorrhea, which are signs related to the ovulation. Factors associated with AUBO include fluctuation in body weight, emotional well-being, and daily activities. It is important to consider the results of previous examinations, as they can provide valuable insight, such as ultrasound, MRIs, or pathological examinations clues to exclude PALM. Additionally, it is crucial to inquire about the past and recent medication and treatment history to rule out any potential correlation between AOB and medications or treatment, that is AOBI, as well as to assess the impact of the homeostatic therapies and the effects of past medical management. Furthermore, gathering information about the patient's medical history, such as cardiovascular conditions, clotting disorders, previous cesarean sections, and uterine artery embolizations, is also essential. The part 2, physical examination. The diagnosis of AOBO was confirmed through a comprehensive physical examination in order to rule out other etiologies for AOB. The physical examination includes a general examination and a gynecologic examination. General examinations include assessment, consciousness, mental state, facial expressions, and overall appearance. Evaluate the extent of blood loss by monitoring vital signs such as heart rate, respiratory rate, and blood pressures in patients experiencing severe acute AOB. Record the height and the body weight. Observe the skins for signs of anemias, acanthosis nigricans, acne, subcutaneous hemorrhagic spots, and ecchymosis. Take notes of amount of distribution of body hair and access for the hirsutism. Examine the thyroid glands for any signs of enlargement. Assess the breast development and check for the presence of the gallicoturia. Observe for abdominal distensions, palpable masses, tenderness, and rebound pains. For the gynecological examinations, the vulva access the blood stains to estimate the extent of the hemorrhage, determine the origins of the bleedings, whether it is from the urethral or vaginal orifice or anus, in order to exclude other potential source of bleeding. For vagina, evaluate the quantities and nature of the blood present, distinguishing between the fresh and old blood to determine if active bleeding is occurring. The cervix. Ascertain if the bleedings originates from the uterine cavities, specifically from the opening of the cervical canal. Assess for any bleedings, lacerations, growths such as cervical polyps or cauliflower-like masses, or prolapse of submucosal uterine fibroid. Observe if the cervical opening is dilated and check for any contact bleeding in the cervix. Uterine body and adnexia. Palpate the size of the uterus and adnexia, noting the presence of any abdominal masses, tenderness, or rebound pain. Part 3, auxiliary inspection. Help to determine the severities and etiologies of AOB, include blood routine test, pelvic ultrasound, hormone measurement, and a coagulation test. The blood routine test. It is advisable to conduct a blood routine test as part of the standard protocols for every patient with AUB. The blood routine test serves a multiple purpose. It aids in the identifications of anemias, hematological disorders, infections, and other underlying medical conditions. It helps evaluate the extent of bleeding and rule out the possibilities of AUB with coagulation, that is AUBC, coagulopathy. It provides valuable guidance in determining the appropriate clinical approach and management strategies. Evaluate the extent of a hemorrhage. Both chronic AUB and acute AUB with significant blood loss can result in iron deficiency anemia. The declines in hemoglobins levels in routine blood tests is more pronounced, and the severity of anemia can be categorized based on the hemoglobin levels, such as mild, moderate, severe, or very severe. Hematocrit levels may also be reduced, but it is important to consider plasma volume and red blood cells volume when interpreting these results in conjunctions with hemoglobins and red blood cell count. The white blood cells and platelets counts typically remains within normal range. However, in case of severe anemias, there may be a slight decrease in white blood cells and platelet counts. It is worth noting that in situations of acute blood loss due to the AUB, the red blood cells and hemoglobin levels may not accurately reflect the immediate absence of blood loss. Therefore, the determinations of the blood loss severities should consider both the actual bleeding situations and the physical examination findings. So when accepting routine blood test reports in patients with chronic AUB, it is crucial to ascertain whether the individuals has been taking anemia-correcting medications like iron to avoid misjudging the extent of blood loss. Routine blood analysis can aid in the exclusion of AUB from hematological disorders such as aplastic anemias, various forms of leukemia, and thrombocytopenias caused by diverse etiologies. If any abnormalities are detected, it is imperative to promptly consult the relevant specialist and make appropriate referrals for accurate diagnosis and timely intervention. In cases where myeloproliferative disorders or essentially hemocytosis are present, there may be significant elevations in platelet count. So it is crucial to exercise caution regarding the risk of thrombosis during the subsequent AUBO treatment with sex hormones, particularly when administered in large doses. The pelvic ultrasound is advised for all patients presenting with AUB. In AUBO, ultrasound typically does not exhibit distinctive specific features, with the exceptions of prevalent PCOS observed in patients with PCOS. The primary objective of pelvic ultrasound is to identify the indications of PALM, AUBI, and AUBN. This aids in the ruling out other potential causes of AUB and facilitating the diagnosis of AUBO. Furthermore, pelvic ultrasound provides insight into the morphologies and thickness of the endometrium, serving as an indicative measures of the influence of estrogens and progesterones. However, It is crucial to acknowledge that the thickness of the endometrium observed during the ultrasound examinations in the presence of bleedings can be affected by the presence of the clots. So patients exhibiting a thickened endometrium, such as those experiencing withdrawal bleedings, may be at risk of excessive bleeding and necessitate proactive management of anemias that we use in the tranexamic acid and iron supplementation treatment at the same time. It is essential to highlight that the individuals with AUBO should prioritize the clinical presentations when determining the treatment options rather than relying solely on the endometrial thickness. The ultrasound characteristics of other causes of AUB will be discussed in detail by Professor Goldstein. The hormone levels, the serum concentrations of follicle-stimulating hormones, luteinized hormones, prolactins, estradiol, testosterone, progesterones, as well as the urine or blood human chorionic gonadotropins, and the thyroid functions were incorporated in the evaluations of underlying causes of AUBO. Nevertheless, it is imperative not to delay treatment while awaiting test results, particularly in case of acute AUB, and instead promptly administer the appropriate interventions. Checking basal body temperatures like BBT can provide valuable insight into the regularities of bleedings and ovulation, aiding in the analysis of the underlying causes of bleeding, particularly in case of the intermenstrual bleeding. Additionally, BBT monitoring is beneficial for assessing the ovulation patterns in case of a chronic AUB. The test parameters, timings, and precautions. The relevant parameters can be assessed during the initial diagnosis, and it is not mandatory to conduct the test in the fasting state. The result should be interpreted in conjunctions with the patient's symptoms, signs, ultrasound findings, and menstrual cycle. Efforts should be made to minimize the influence of exogenous sex hormone medications on the test result. Ideally, the test should be conducted prior to the initiations of hormone therapies or at least 1 month after discontinuation. It is important to emphasize that in patients with AUBO, hormone testing is conducted to determine the underlying causes and not to dictate treatment options for the patients. Assessing sex hormone levels at the different phases of the menstrual cycles yields varying normal values and conveys distinct meanings. During the follicular phase, hormone levels can provide insight into the baseline status of the sex hormones. During the luteal phase, hormone testing for estradiols and progesterones is conducted 5 to 9 days before the estimated next menstrual period. This helps determine the presentations of ovulation and assess the luteal function. Additionally, it is the optimal timing to analyze the causes of light menstruations. It's very common in Chinese complaints in conjunctions with the ultrasound to evaluate the thickness of the endometrium to seek for the reasons for the light menstruation. The estradiols can assess the etiologies of amenorrhea and oligomenorrhea. The progesterone determine the ovulations and evaluate the luteal functions. Total testosterone measured in serum is served as a crucial indicators of menstrual disorders and hyperandrogenemia. However, its levels may not entirely correlate with the symptoms of the hyperandrogenism due to the active form being free testosterone, which is influenced by various factors. Prolactin, a notable increase is observed in menstrual disorders and reproductive dysfunctions caused by hyperprolactinemia. The causes of elevated prolactin levels necessitate analysis. Contraceptions, gonadotropins, including FSH and LH, both hormones exhibit low fluctuations during the follicular and luteal phase. FSH and LH levels rise at other times except for the peak before ovulation. An increased FSH levels may indicate decreased ovarian functions or ovarian failure. These values aids in determining the etiologies of the amenorrheas and evaluating ovarian function. The beta-HCG, it is imperative to exclude pregnancy as possibilities. So blood beta-HCGs provide a great accuracy, while the uterine HCG serves as a rapid method for ruling out pregnancy. The coagulation functions, rotem prothrombin time, and APTT testings are not recommended for all patients with AOBO. It is advisable to include blood coagulation tests for diagnostic purpose in the following situation. Number one, experience excessive or spontaneous bleeding symptoms immediately after the menarche. Second, presenting with substantial amounts of the vaginal bleedings or recurrent bleedings after excluding structural abnormalities as a cause, and when the effectiveness of conventional hormone therapy is unsatisfactory. Third, the concurrent abnormalities in liver functions, kidney functions, or spleen enlargement, which can lead to coagulation abnormalities. Fourth, receiving anticoagulant medications such as warfarins, heparins, or changed medicines with unknown composition. Fifth, suffering from severe nutritional deficiency as prolonged lack of the oral intake or reliance on parenteral nutrition can result in vitamin K deficiency. Sixth, having a family history of congenital hemorrhagic disease. So if feasible, perform a comprehensive set of coagulation functions tests, including the PT, APTT, fibrinogens, FDP, thrombin times, D-dimer, to confirm the diagnosis. So in summaries, the clinical assessment of the AOB or AOBO include the history inquiry, the physical examinations, and the auxiliary inspection. The diagnosis of AOBO is an exclusion diagnosis. It should be differentiated with the palm corn, except the AOBO. So a correct diagnosis of AOBO can guarantee the effective medical treatment. So thanks for your listening, and thanks for the interpreter's works. Thank you.
Thank you so much, Professor Tian. That was a very comprehensive and clinically oriented presentation, and I think that was absolutely within the scope of this webinar. So we want to be as clinical as possible in presenting the correct approach or for the clinical assessment in this case, and for what follows up. The diagnostic imaging techniques that are required to assess how abnormal uterine bleeding issues and therefore, to pave the way for the management of the problem. So thank you. That was absolutely fantastic. So it's before introducing Professor Goldstein, who's our next speaker, I would like to remind everybody who's listening that if you have questions, and I'm sure there will be a lot of questions, please write them in the Q&A, in the question and answer area, which is down in the Zoom window. So you just have to write them there, and we will collect them at the end of the webinar during the question and answer time. So Professor Goldstein, Steve, Professor Goldstein needs no introduction. He's a renowned expert in the field of hysteroscopic diagnostics of uterine disorders, as much as many other things in his long and illustrious career. Steve, if you want to start your presentation, you are free. Just share your screen and we will listen.
Okay, so as you can see, this is entitled Menstrual Cycle Bleeding Disorders. So I wanted to start with what I call Histology 101. And this is all very familiar to most of you, but it's worth trying to correlate what you might expect to see with imaging with what's going on in histopathology. Hormonal status obviously affects endometrial thickness. The endometrium consists of a basalis and a functionalis. Estrogen causes the functionalis to proliferate. Proliferative endometrium is characterized by abundant mitotic activity. And if you look at this hysterectomy specimen done in the proliferative phase, you see typical proliferative endometrial glands. And if we look at them in higher power and even higher power, almost every one of these nuclei is mitosing, having a mitotic figure because it is actively proliferating. And if we look at this patient with a transvaginal ultrasound, here's the footprint of the transducer, the uterus and long axis. This is the endometrial echo. This white line here is actually the interface between two sides of proliferating endometrium. And we sometimes call this multi-layered. You can see the sonolucent area on this side and then the echogenic area down towards the basalis. Progesterone, or in sequential hormone therapy, the use of a progestogen converts this estrogen-primed functionalis to a secretory phase. Secretory endometrium appears thick and echogenic on transvaginal ultrasound. And you can see in this hysterectomy specimen, the glands kind of line up in a very linear fashion. And so when we look at these with ultrasound, we get this fiercely homogeneous echogenic endometrium in the secretory phase of the cycle. After shedding of the functionalis, the basal endometrium that remains is initially quite thin, and I describe this as a pencil line appearance on transvaginal ultrasound. Here's a woman who's just finished bleeding, so she's day 5 or 6 of a cycle, and this white line represents the interface between two sides of basically inactive basalis, and you can see recruiting of a couple of follicles here in one of her ovaries. In menopause, there is no estrogenic stimulation of the functionalis, and so the endometrium becomes atrophic. And if we look at this menopausal patient, once again, this thin white line represents an interface between two sides of inactive atrophic endometrium. So if we think about abnormal uterine bleeding, the old terminology, and hopefully in the question and answer, I want to go into this in more detail. Menorrhagia was heavy menstrual bleeding. Metrorrhagia was abnormally time bleeding. And in my opinion, unfortunately, we have let go of these terms because I think these terms, if a patient gives you a good menstrual history, can be a very good clue to what the potential etiologies may be. But as you all know now, this has been replaced with an umbrella term of AUB, or abnormal uterine bleeding. And we now have this palm coin situation. And the way I kind of think of this or explain this to our students is really what we're talking about is structural versus non-structural. okay? Which as a clinician means to me either operative hysteroscopy if there's something structural versus either hormonal or expectant management if it is non-structural. So, and realize this is very important. To our patients, all the blood that comes out of their vagina is their period. But to me, a menses is a bleed preceded 2 weeks before by ovulation or by the use of sequential hormone therapy in a menopausal patient. The word "an" in anovulation is actually from the Greek, meaning without. So what causes the bleeding when there's no ovulation in a patient who is anovulatory? Fluctuations in estradiol will destabilize the proliferating functionalis, and thus anovulatory bleeding, also known as DUB or dysfunctional uterine bleeding, is sometimes termed estrogen breakthrough bleeding. Furthermore, postmenopausal bleeding is not so easily defined. In other words, we know that menopause is the final menstrual period, but obviously this is a retrospective diagnosis. No woman knows that the bleed she just got is the last one she will ever get. So we also use a classic definition of no bleeding for 12 months due to a depletion of ovarian follicles. Therefore, I hope you understand that a serum measurement of follicle-stimulating hormone or estradiol can be notoriously unreliable because that is just a snapshot of ovarian function at that time. And in perimenopause, there is great fluctuation in ovarian function where it may be absent one day and a month later resume. In fact, it's this erratic function of the ovaries in late perimenopause that often makes it difficult to label bleeding as being definitively postmenopausal or perimenopausal. But in clinical practice, it may not matter because we teach even the students that postmenopausal bleeding is endometrial cancer until proven otherwise and has to be evaluated. And for instance, in the States, the American College of Obstetricians and Gynecology in 2012, which has been reaffirmed many times, mandates that endometrial assessment to exclude cancer is indicated in any woman older than 40 years who's suspected of having abnormal uterine bleeding. So whether that 51-year-old is in late perimenopause or is menopausal, if she has abnormal uterine bleeding, we must evaluate her endometrium regardless. I say here that you can use transvaginal ultrasound in the first step in evaluating all cases of abnormal uterine bleeding, as long as you understand the difference between patients who cycle versus those who do not. In non-cycling patients, this would be menopausal or women on continuous combined hormones or birth control pills, every day is the same. And so the timing of your ultrasound examination is not crucial. But in patients who are cycling, timing is crucial. If you're going to use ultrasound, you want to perform it at a time when the endometrium will be as thin as it will be all month long, usually just as the bleeding cycle ends. And this prevents misinterpretation of a heterogeneously thickened endometrium later in the cycle as being pathologic. So for instance, this is now a saline infusion. We put some saline into the endometrial cavity late in the cycle. You see how irregular or heterogeneous the endometrial cavity can be. These women have had C-sections, they've had D&Cs, they've had deliveries. These are what we call endometrial moguls. You know, is this focal pathology? If you do your evaluation later in the cycle, you can be misled. Or another example with saline infused here, you see that topographically, the endometrial surface is not always homogeneous and smooth later in the cycle. And for those of you who go skiing, we have labeled these endometrial moguls. And if we look hysteroscopically at this patient later in the cycle, this is not necessarily abnormal. This is not a small polyp. This is the way the endometrium can lay itself down during the course of a normal cycle. So the question then comes up, what is the proper use of transvaginal ultrasound in the clinical evaluation of patients? And that's assuming you're performing it at the proper time. And the answer is the high negative predictive value of a thin, distinct echo on transvaginal ultrasound in patients with bleeding. Patients who are not bleeding and have an incidental finding of a thick echo, that's an entirely different story, and maybe we'll have a webinar someday on the incidental findings in the asymptomatic patient. Some general principles: if you do ultrasound or you order it, the higher the frequency transducer that still gives adequate penetration should be utilized. Once the endometrium is visualized, you want to use as much magnification as possible. We get multiple images in the long axis plane to the midline as well as to the right and left of midline. And we want to measure on the long axis at the thickest point. So for instance, here's a clip of the endometrial echo. You can see this uterus is somewhat axial, a little bit retroverted. If we freeze the frame, you want to measure at a right angle. You do not want to measure at a skewed angle. Here's another example. This thin, I mean, I almost can't get the calipers far enough apart in this patient who has no tissue. This is a very reliable indicator of the lack of significant tissue. It's essential that you understand that not all uteri lend themselves to a meaningful ultrasound examination. The axial uterus, some people used to think it was the retroverted uterus. The closer to a right angle the beam of sound is to what you want to look at, the better you will see. So the uterus that is axial in the same plane as the beam of sound, it's very difficult to image. Marked obesity. You all know that the woman with a BMI of 40 has a huge panniculus, but the entire peritoneal cavity is surrounded by some fat. Not as much as the abdomen. When you put a probe into the vagina, the fat attenuates your sound beam. Coexisting fibroids, adenomyosis, previous surgery. Just because you can wiggle the transducer, find something linear and white, freeze the frame and put on the calipers doesn't mean that is the endometrial echo. You never should be afraid to say the endometrial echo is not well visualized enough to use this technique to exclude significant pathology. For instance, here's a woman with some fibroids. You can see the acoustic shadowing. I have no idea what her endometrial echo measures. I am incapable of finding a reliable endometrial echo. Or here's a patient with marked adenomyosis. There's a little bit of an echo here, but I'm not going to stake my reputation. You would have to go to some alternative, and we'll talk about what those are shortly. Or the patient, this woman, I call this a C-section uterus. This doesn't exist in nature. The cervix comes in anteriorly and the fundus takes this 90-degree turn. You can walk in a room and see that this woman has had a C-section. In addition, her endometrial echo is in the same plane as the beam of sound, which is why we are not visualizing it. If this were antiverted, you would see it nicely. If it were retroverted, you would see it nicely. But in this axial plane, we don't see an endometrial echo. These abnormalities are not always global. Realize that if somebody takes an ultrasound and shows you a frozen image, that is a two-dimensional snapshot. And a two-dimensional snapshot does not rule out pathology. You must recreate three-dimensional anatomy. So for instance, here is a very normal-looking endometrial echo, no pathology, but this is to the left of midline. If we move over to the right of midline, there's an obvious polyp at the fundus. And if we turn our transducer into a coronal orientation, in the lower uterine segment, this looks perfectly normal. When we go to the fundus, here's our polyp. So I hope you realize that long axis view here produced the image of the polyp. The long axis view here looked perfectly normal. You must mentally or with technology recreate three-dimensional anatomy. Or here's an example of what looks like a very normal situation. We look at this in a clip and you'll see as we turn into a coronal plane, this little polyp is actually way off into the corner of the uterine cavity. Must recreate three-dimensional anatomy. I say here the standard of care has changed, but how many clinicians are aware of it? The reliability and I think liability of blind endometrial sampling has radically changed. So why is there an issue with such sampling? This is very interesting. In the States in 1991, this guy, Tom Stovall, took 40 women with known carcinoma, brought them to the clinic 1 week before their hysterectomy. He did blind endometrial sampling, actually using a pipelle device. He got cancer in 39 out of 40. Hence, he said it was 97.5% accurate. And this was highly publicized by the makers of this device. And there was a rapid change in the standard of care where people use this device, which actually was developed to do endometrial dating as part of an infertility workup, was never meant to be the standard for ruling in or ruling out cancer, but everybody flew to this. Many other studies were similar. Ferry, using the same device, in patients with known cancer, missed almost a third of the cancers doing blind sampling. Larson, using a Z sampler, missed almost 18%. But this paper by Guido really was great. In other words, Guido had 65 women with known cancer. He did a pipelle in the operating room under anesthesia prior to their hysterectomy. They missed 16% of the cancers, but he did us the favor of opening the uterus after the hysterectomy. And notice that when the cancer occupied less than 50% of the surface area, that constituted all of the 11 they missed. But if the cancer occupied more than 50% of the surface area, blind sampling always found it. And the ACOG practice bulletin, which I will go over, which was first published in 2012, but has been reaffirmed many times since, tells us more about this. It tells us that 1/3 of outpatient visits to the gynecologist are for abnormal uterine bleeding, and it accounts for more than 70% of GYN consults in the perimenopausal and postmenopausal years. It tells us that in women aged 40 to menopause, AUB may be due to anovulatory bleeding, which represents normal physiology in response to declining ovarian function, but may also be due to endometrial cancers, hyperplasias, or fibroids. It tells us the primary imaging test of the uterus for the evaluation of AUB is transvaginal ultrasound. It says if transvaginal ultrasound images are not adequate or further evaluation of the cavity is necessary, then sonohysterography, also sometimes referred to as saline infusion sonohysterography or SIS, or hysteroscopy, preferably in an office setting, is recommended. Now, let's talk a moment about sonohysterogram. This is putting fluid into the uterus to further enhance the ultrasound detail of the endometrium. They're among the easiest transvaginal ultrasound scans you will ever perform. The technical aspects are relatively simple for gynecologists, slightly more daunting for those who only do radiology, who are not used to accessing the cervix and cannulating the cervix. Remember, fluid enhances sound transmission. That's why ultrasound is so valuable in obstetrics. Baby is in a bag of water. That's why we have all these pretty baby pictures. So I never did a residency in radiology. My first understanding of ultrasound is fluid is your friend. I often say, think of the baby with polyhydramnios, how well you can see. Think of the baby with oligodramnios, how poorly you can see. This is an old static arm ultrasound image. This is not the urinary bladder. This is a woman with massive pelvic ascites. The uterus is floating in a sea of ascites. You can see the attachment of the uterus to the pelvic sidewall. Why? Because there is acidic fluid. Or not my prettiest picture of a fimbriated end of the fallopian tube, but I like this one because you can see a hydatid Morgagni. Why? She has ruptured a functional cyst, and the fluid backdrop enables us to see quite beautifully. Or a premenopausal dominant follicle in an ovary. My nephew could find this on ultrasound. It lights up like a Christmas tree, as opposed to a postmenopausal ovary. Without the fluid-filled follicles, they are not so easy to find on ultrasound. So sonohysterography, putting fluid into the uterine cavity, should be thought of as a subset of transvaginal ultrasound when the endometrium is not sufficiently thin or It's not well visualized, as I showed you before, adenomyosis, fibroids, axial uterus. So we wrote this paper quite some time ago, and it was an ultrasound-based triage. We had 433 patients. They averaged an age to be 47. They were all perimenopausal, and they had any degree of abnormal uterine bleeding. A couple of the saline infusions. Here was an example of a submucous myoma. You can see that the cavity here is lined by very thin endometrium. We do this purposely as the bleeding cycle has ended. But is she a good candidate for resection? And the fact that there's a good 1.2 centimeters from the back of the myoma to the serosa makes her an excellent candidate for resection. Or here's a more modern example of a saline infusion. We were unable to see without putting fluid in. By putting fluid into the uterine cavity, you can now see that this woman has a very, very thin endometrium surrounding it. She has no organic pathology, no structural abnormality. She does not need a biopsy. She does not need a hysteroscopy or D&C. But here's an example of saline infusion showing a focal abnormality. See, this is done right as the bleeding cycle has ended. The endometrium is actually quite thin, but there's this endometrial polyp. This will be removed under direct vision at the time of hysteroscopy. And the blind sample, if it doesn't get a piece of this polyp, could be misleading. Here's an example of what looks like a relatively thickened endometrial echo. We put some fluid in, and in fact, we see the tissue surrounding the fluid is relatively thick, but it is symmetrical. It is symmetrical. It measured almost 5 and 4 millimeters respectively. But because it's symmetrical, blind sampling will be reliable. It doesn't matter where I get my piece of tissue from. So of our 433 patients, almost 79% had dysfunctional anovulatory bleeding, no structural abnormality. Only 5.3% had submucous myomas, although approximately a third of these women had any fibroid changes on ultrasound. About 13% had polyps, and about 3.5% had hyperplasias, of which 5 were symmetrically thick, 4 were focally thick, and 6 were in polyps. So what about office hysteroscopy? And I would say as an aside, if you have this available, this can be substituted for saline infusion sonohysterography. They really are relatively equivalent for diagnostic purposes. In the past, I had previously not done any office hysteroscopy because of the space needed for the equipment, the need to be able to sterilize the equipment, the time involved, as well as issues of patient comfort and discomfort. Thus, in my hands, office hysteroscopy in the past was not a satisfactory option, and therefore definitely was not point of care, something I could do for the patient when she came to visit me. But these newer disposable hysteroscopes can certainly be an alternative to saline infusion sonohysterography for selected patients in an office or clinic setting. So I'll show you a few cases with the disposable hysteroscope. And I do this diagnostically because if there is a structural abnormality, I then bring them to the operating theater, give them anesthesia, and do operative hysteroscopy. I am just doing this hysteroscopy from a diagnostic point of view. So here I put my scope in, and very quickly you're going to see 2 relatively sessile polyps. Well, I take more pictures because I'm showing this to you, but at this point I'm done. I remove my scope and I make arrangements to take her to the operating room or theater, as some people call it, to remove these. Here's an example of a submucous myoma. You can see the coarse vessels that are typical, often seen on the face of the myoma. The rest of this cavity, this patient has just finished her bleeding cycle, is relatively devoid of any tissue. This also will be resected in an operating room setting. This was a patient who was on tamoxifen. Clearly, this is not a thin endometrial echo. It's got some of this microcystic change, which is typical of SERMs. You could do saline infusion on this patient, but instead it was very easy to slip a disposable hysteroscope in, and you see she's got all of these small polypoid changes, very typical of tamoxifen. I made up a new word I was once told. I said that tamoxifen is polypogenic, if there is such a thing. And this, when you remove a tamoxifen polyp, those sonolucent areas on ultrasound represent glandular cystic atrophy. These are dilated atrophic glands lined by a single layer of low cuboidal epithelium that can be located in the polyp or else in the actual basalis of the endometrium as well. Dysfunctional uterine bleeding. Well, here's a patient where I really don't see her endometrial echo very well. I could put saline in here to see better, but instead in this Paris woman who's perimenopausal, I slip in my disposable hysteroscope, and you will see in a moment. This is now just fluffy tissue. Now, keep in mind, she's been bleeding irregularly. So some of these erythematous areas are denuded areas, and some of this is endometrial tissue. But this is not a polyp. This is just some of this fluffy tissue. And in a case like this, because it is global, it enables me to do blind endometrial sampling. The path revealed proliferative endometrium. What we often tell patients is hormone imbalance, and she could be treated hormonally and can avoid any operative hysteroscopy. This is a patient with a previous history of complex hyperplasia without atypia. She does not have a thin, distinct endometrial echo. We slip the hysteroscope in. Now, be careful about trying to make a diagnosis visually. I know this looks very confluent. These are areas that are denuded because she's been bleeding, but because there's no focal abnormality, a patient like this can undergo blind sampling. It revealed the recurrence of her complex hyperplasia. In spite of no atypia, she opted for hysterectomy instead of another prolonged course of a progestin. So back to the ACOG practice bulletin of July 2012, it does say that an office endometrial biopsy is the first-line procedure of tissue sampling in the evaluation of patients with abnormal uterine bleeding. It says that such a biopsy has high overall accuracy in diagnosing cancer when an adequate specimen is obtained, and even more importantly, when the endometrial process is global. If the cancer occupies less than 50% of the surface area of the endometrial cavity, the cancer can be missed by a blind endometrial biopsy sample. A positive test is more accurate for ruling in disease than a negative test result for ruling it out. This is always true in medicine. These tests are only an endpoint, they mean biopsy, when they reveal cancer or atypical complex hyperplasia. Let me repeat that. Simple blind endometrial sampling is an endpoint only when it reveals cancer or atypical complex hyperplasia. Our registrars at Bellevue Hospital don't have access to ultrasound. Of course, they will do blind endometrial sampling first, but if this does not reveal cancer or atypical hyperplasia, the workup is not complete. So now that the standard of care corroborates that a negative blind biopsy is not a stopping point, certainly clinicians can begin with a biopsy, but unless it is malignant or complex atypical hyperplasia, the endometrial evaluation is not complete. So in summary, the main use of endometrial thickness measured on transvaginal ultrasound is the high negative predictive value of a thin, distinct echo. And if you, some of our registrars, stripe is not a stripe, it is an echo. In premenopausal patients with AUB, an echo, we say less than 5 millimeters early in the cycle excludes significant pathology. Otherwise, saline infusion, sonohysterography, or disposable office hysteroscopy can distinguish global from focal processes and allow appropriate next step triage. New understanding about the high reliability of transvaginal ultrasound with sonohysterography where necessary, as well as understanding the limitations of blind endometrial sampling will result in increasing importance and utilization of transvaginal ultrasound and office clinic-based hysteroscopy in this common clinical entity of AUB, I think, in the years to come. And I thank you very much for your attention.
Thank you very much, Professor Goldstein. I think you gave a very simple yet very detailed overview of how to use correctly both sonography and saline infusion sonohysterography, and of course office hysteroscopy, which is a very important trending topic for the approach to any type of intrauterine disorders. So, ladies and gentlemen, we are now open for discussion. I have a few questions on the Q&A section. So let me just remind everybody that if you want to ask questions, you have to write the questions in the Q&A box, and then we will try to discuss them. So before getting into the specific questions that have been proposed by some of the participants, I'd like to ask you both, Professor Tian and Professor Goldstein, to try and integrate a little bit from your relative point of views, the areas that you had to cover. So both the clinical assessment and the let's stay with the sonographic assessment, which is probably what most gynecologists are now performing every day. So when you approach a woman with abnormal uterine bleeding, how do you weight in your clinical practice the anamnestic findings? So how do you value the storytelling of the woman that describes how her problem has ensued, the duration, the frequency, how heavy is the cycle, with your sonographic findings? So what do you think is most important? So maybe Professor Tian or Professor Goldstein.
I'd love to jump into that because that's a great segue into something I alluded to. I think a very good menstrual history, if it's available, will give you tremendous clues. And what I mean by that is some women are bleeding so much so often they really can't help you. But other women have, especially now with these new apps, have a very good handle on when they bleed. And so, you know, getting rid of the terms menorrhagia and metrorrhagia, I think, was a huge mistake. And so when I meet with the students and the junior registrars, when I get a new group, I used to love to ask them, what is menorrhagia? What is metrorrhagia? And they would regurgitate the answer, you know, heavy menstrual bleeding, bleeding between periods. And then I would ask, do you think that menorrhagia cancer causes menorrhagia? Blank stares. And then maybe the first year registrar would sheepishly say, yeah, I think so. And I'd say, so you think cancer bleeds heavily every 28 days? No. In other words, I think that understanding if patients have a good menstrual history, what causes heavy menstrual bleeding, but where the timing is normal, adenomyosis, polyps that are in synchrony with the cavity. I also think there's an entity that no one ever talks about, which is big cavity. Somebody has 4 children, the surface area of the endometrium will be like the inside of a tennis ball, not a ping pong ball. It's just more tissue to come out. What causes intermenstrual bleeding? Well, as we heard very nicely from Dr. Tian in our study, dysfunctional and ovulatory bleeding is the most common reason for irregular bleeding. But then you have to start to think about hyperplasias, cancers, polyps, submucous myomas. But I think that the good menstrual history, which often is, you know, the patient comes in and says, well, I'm having abnormal bleeding, and people do not take the time to really pin down. I think this is crucial.
Well, thank you, Professor Goldstein. Professor Tian, what's your opinion?
I totally agree with Dr. Goldstein's idea. I think that the history inquiry is the most important. After you get a detailed history of the inquiries, you can get the 80% of the correct diagnosis. But at the same time, you need to do a very quickly general examinations and just to see where the bleeding comes from, whether it's active or just some very slow or chronic the bleedings. At the same time, we just recommended the blood-urine test and the pelvic ultrasound. These 2 items is basically or essential for the differential diagnosis. But I still agree with Dr. Goldstein that the medical history is most important.
Well,
the other thing
yeah.
that I would mention, Tommaso, that I think that I didn't really say that I think is so crucial. I am very, very, very liberal in perimenopausal women with what my teachers called a progesterone challenge test. In other words, if patients are having dysfunctional anovulatory bleeding, they may have finished bleeding yesterday and still have a big, thick endometrium because they can bleed heavily but not empty the uterus if it hasn't converted from proliferative to secretory. And if you think about the fact, we treat everything up to stage 1 cancers in people who want to retain their fertility with progestins, right? So if there's any doubt in my mind, and most of these people may have dysfunctional anovulatory bleeding, a liberal course of a progesterone challenge test, which then induces a withdrawal bleed, and then time your ultrasound examination to a progesterone, related withdrawal bleed, because then you will not be, should not be misled. And after a progesterone withdrawal bleed, you don't have a thin endometrial echo in the first 1, 2, 3, 4, 5 days. You have to start to think about some truly structural abnormality. So very liberal use of progesterone. And then the other comment I wanted to make that I have only become, I will admit, for 30 years, I would say to patients who came in with heavy bleeding, but they had wonderful hemoglobin and hematocrit, I'd say, well, at least you're not anemic. It's a social issue, not a medical issue. Recently, we have begun much more to become aware of iron deficiency before anemia. Iron deficiency without anemia, low iron stores, can cause fatigue, restless leg. And so I used to only order, hemoglobin and hematocrit, but iron stores are extremely important, and iron supplementation. And I will be honest enough that for much of my career, I didn't appreciate that. I only looked for anemia. I didn't look for iron deficiency prior to anemia. So I suggest that you add that to your armamentarium.
Yeah, that is very true. That is very true. And anyhow, any woman who complains about abnormal uterine bleeding, even if it's just a social problem, I think anyhow she deserves some sort of solution. So yeah, but the amount of impairment on quality of life, just to be very simple, that bleeding irregularly provides to a woman is something that needs to be addressed independently from medical issues, which you are very right. Sometimes are need to be explored even before the relevant reaching anemia. So let me pick some of the questions that come from the audience. There's a couple of questions. Two first questions were on how and where performing endometrial biopsy. So let me implement a little bit, because that might be probably a little bit too general to be discussed. But Steve, you have discussed a little bit on the techniques on the how to perform endometrial biopsy based on whether the pathology that you see is generalized within the uterus or whether it's focal. So that of course makes a big difference. But would you actually specify a little bit better whether you think it's always necessary to pick a biopsy when you don't see any visible disorders, particularly in the setting of a patient that is being worked up for something that is supposed to be an ovulatory bleeding, so something that is not structural in theory. So how do you behave? And Professor Tian, if you want also to add.
Yeah.
So go ahead.
Please.
Go ahead, Professor Tian. Yes.
If I after ultrasound, if there's nothing that can be found with abnormalities, and we usually will give some the medications such as the progesterones or COCs, try to stop the bleedings. But if the effectiveness of conventional medicine doesn't work or doesn't have a very satisfactory effects, we'll recommend the patient to have further tests. For example, to have the hysteroscopies, try to exclude other reasons of the AUB. Yeah. That include the AUBM, let's say atypical hyperplasia, or just the hyperplasia with or without typical hyperplasia.
Yeah.
I mean,
5 days
also,
is
and
good,
I think if I understand your question properly, I mean, I just even had a patient, I saw a few patients this morning before they got onto the Zoom. And one of them, for instance, had a thick endometrial echo, which I am pretty sure is dysfunctional and ovulatory. So what I will do, rather than a biopsy, because I am fairly convinced she has no other risk factors, that this is almost certainly, if I did a biopsy, going to just be proliferative. It's an estrogen effect. I give that course of a progesterone challenge. I tell them to come back in the first 1, 2, 3, 4, 5 days after the bleeding ends. That's progesterone withdrawal. And if she has a thin white line, I have proven there's no anatomic abnormality, and I do no biopsy, I do no hysteroscopy, I know no saline infusion. In other words, she has responded and that's the treatment for dysfunctional bleeding, unless you're going to put her now long-term on combined oral contraceptives, or perhaps not a big fan of Mirena IUD for this purpose. In other words, that's good for heavy menstrual bleeding, but I'm not a big fan of it for dysfunctional and ovulatory bleeding. If there's no contraindication, I prefer combination oral contraceptives. But here's an example where the use of progestational agent, follow-up ultrasound, thin distinct echo, I've clinched the diagnosis. It was dysfunctional and ovulatory bleeding. I don't need tissue sampling.
Yeah, correct. Steve, there's just a latest question that just came in from Brazil. The colleague, Dr. Tettelbaum, would like you to repeat how you actually perform the progesterone challenge, the progesterone withdrawal.
Yeah,
So do you use MPA? What's the dosage? How many days? Yeah.
Sure. I mean,
Quite
and this
classical,
is,
but yes.
yeah, it's not. I tend to use medroxyprogesterone acetate because that's what I was trained on. I do think that it is a better endometrial drug, a little bit better than natural progesterone. Natural progesterone works well in the overwhelming majority of people, but I have had a handful who didn't respond to the 200 milligrams of natural progesterone, and then when they were given medroxyprogesterone acetate, they did respond to that. So I tend to do 10 milligrams of medroxyprogesterone acetate for 10 or 12 days, depending. I mean, it just to give enough progestational support to convert proliferative functionalis to a secretory phase, and then it should be passed in its entirety.
Yeah, I've been personally used to use MPA 10 milligrams twice a day for 5 days, and you generally get a bleeding. But I understand you do it on a longer term, so that's very interesting. So yes. There's a couple of questions which I think are very interesting. One is by Dr. Moreau, and she's asking whether focal adenomatosis that you might pick up with the ultrasound or with the hysteroscopy, whether these can cause abnormal bleeding, which I think is very interesting, because sometimes we have patients who bleed abnormally. We find a small polyp. So is the polyp the leader? So are we solving the bleeding if we remove the polyp? How can we foresee? Maybe you want to comment on this. Of course, we don't know for sure, but yeah.
These are two great points. One is sometimes you get sucked in, as I say. Patient has AUB, she's 47 years old. You do this workup, you find a small polyp. I remove the polyp, obviously. I'm not going to say, well, it's obviously dysfunctional and ovulatory. You have a structural cause. But I warn these patients, and one of our registrars did a study, that polypectomy worked about 85% of the time. Sometimes you may have dysfunctional and ovulatory bleeding coexisting with an inactive polyp. And just because a polyp is there is no guarantee it is the source of the bleeding, yet you get sucked into having to remove the polyp. But I warn these people that if the bleeding persists, it could still be hormonal in nature. You haven't ruled that out just because you find a structural abnormality as the source. The question about adenomyosis is extremely interesting too. I think adenomyosis is much more prevalent than we have previously thought. I think, there was one study where on a routine hysterectomy that was not for malignancy, if they cut 3 sections in the path lab, the incidence of adenomyosis was 31%. And if they cut 6 sections, it was 61%. Sometimes I think if they cut 9 sections, it might be 91%. And on ultrasound, it is often very easy to see little sonolucencies or a hypertrophy of one wall, usually the posterior wall. The typical ultrasound findings that have been described as being typical of adenomyosis. I think a lot of adenomyosis is asymptomatic. I do believe a lot of it causes pain and bleeding, but we must be careful because what I see happen sometimes, 43-year-old woman having normal cyclic menses, goes for examination. They think she has an adnexal mass. They send her for a sonogram. There's no adnexal mass, but she has adenomyosis. She's absolutely asymptomatic. 3 years later, she starts bleeding twice a month because she has dysfunctional anovulatory bleeding. The clinician says, oh, she's bleeding twice a month. Oh, she has adenomyosis. She needs a hysterectomy. And it's true, and not necessarily related. There's a difference between having an ultrasound finding and having a disease. And I think that we have not established what is the true incidence of asymptomatic adenomyosis. In other words, the people who have pain and bleeding, that's the numerator. The denominator is pain and bleeding plus the asymptomatics. We have never figured that out.
Yeah, that's correct. So we are back again to the solid rule of being anamnestically accurate and trying and understand what's the cause behind things through understanding pathophysiology, I think, of reproductive endocrinology and how the menstrual cycle issues. There's a couple of interesting questions because I think it's something that we encounter in our clinical practice very often with people who are perplexed on how to manage on mucocele. So when you find a cavity, an endometrial cavity full of mucus, it's clearly transonic mucus, so it doesn't look like it's blood. It doesn't look like it's material, but it's mucus. So is this something that requests an exploration? Of course, in case you find a sonographically thin endometrium, particularly, or is it worth an exploration if the patient also bleeds? So how do you manage this type of situation, which are quite frequently, particularly after the menopause?
When you say mucus, you mean a fluid density on ultrasound?
Yes.
Because I think this is more often transudate than it is true mucus, as I think of, let's say, endocervical mucus. But if you're talking about endometrial fluid collections, which I think in postmenopausal women exists in the high single digits. In other words, I think you start looking routinely at postmenopausal women, 7, 8, 9% of these women will have endometrial fluid. It's a sign, I think, of atrophy with some either absolute or relative cervical stenosis, and it provides a naturally occurring sonohysterogram. It enables you to see the endometrium surrounding it beautifully. So if the endometrium surrounding the fluid is thin, then I think you leave these people alone. If the endometrium surrounding the fluid is thick, then I am concerned, could the fluid represent blood, which is not coming out of the cervix because of cervical stenosis? So if you see fluid with a non-thin endometrium, then I think you have to go after it.
Professor Tian?
Yeah, I agree with Dr. Goldstein's ideas because the mucus, usually if the cervical orifice is dilated or opened, usually there's very less amount of the mucus, but if there is some adhesions or the cervical's adhesion, it might be some amount of the mucus that requires the further the treatment. You can try to dilate the cervical orifice, try to reduce. After the treatment, if the amount of the mucus can reduce, that means it's okay. No problem with it. Otherwise, you should try to use the ultrasound or the hysteroscope, try to make sure where and what is it. Yeah.
Yeah, I agree. So it's such a frequent condition that I think it needed a comment. So thanks for to those who raised the issue. So there's a couple of questions which refer more to the early ages, to younger women. One is more related to how do you assess, how do you work up a young woman without the possibility to access to the vagina because she hasn't had yet intercourse, and within the context of what we have said of abnormal uterine bleeding. And on the other side, there's another question on how do you manage a young woman, 14 years, for instance, with irregular bleeding, abnormal uterine bleeding, but who has a normal ultrasound in normal hormone levels, as I said, which is very frequent. So these are difficult managements, I think. So Professor Tian, do you want to start?
Yeah, as in our lectures, we emphasize the age of the AUB. For example, in adolescence, the most common reason for the AUB is the AUBO and maybe the AUBC. Yeah, but most commonly the AUBO. So if the patients, we can after exclusion of the pregnancy, we can do the ultrasound. We can use the blood test. After that, we can diagnose of the AUBO. Then we'll make a choice of the drugs. The most common drugs for the adolescents we use in China is the dydrogesterone because it has the less side effects. It doesn't interfere with the maturities of the IPO axis, and is very effective to withdraw the thickened endometrium and can quite well to manage the cycles of these patients. Yeah.
Yeah, I think of adolescence as the coming on to the reproductive years. It's the mirror image of perimenopause, which is the coming off of the reproductive years. And so if a 14-year-old is having significant enough, dysfunctional anovulatory bleeding, AUBO, combination oral contraceptive pills are my first choice without question.
Yeah. So there's two parallel questions on the estimation of what's the threshold of endometrial thickness as measured by ultrasound in menopause, after menopause. So when you, if you have a critical value that you use in your clinical practice, what's the latest guidelines you want to describe on this? To consider the endometrium at risk for being a hyperplastic. And another question is actually on the side. So when you have a thin endometrium, so up to 4 millimeters, by knowing the fact that there's a certain percentage of these women who might have type 2 endometrial cancer, like serious endometrial cancer. So would you just wait and check for these women, or if you have a consistent and continued bleeding, you would therefore go towards exploration invasive?
Yeah, I think there's your answer. In other words, that's unusual enough. But if there's persistent bleeding, even with a thin endometrium, you've got to get more aggressive. That's all there is to it. In other words, the first episode, somebody comes in, they measure, and I never understand what even measures 3.9 millimeters. I showed you these. When it's truly atrophic, I expect, I can barely measure it. It's such a thin white line. So a little bit of clinical judgment instead of having an absolute number. The example I like to give is, the ACOG has come up with 4 millimeters, and this is in women with bleeding. Please, it's a whole nother lecture. Somebody is asymptomatic, they measure 12. Well, yeah, so what? I mean, the number of people who have asymptomatic polyps who may measure thick, who haven't bled in 20 years, approaches 13%, according to Eva Dreisler's work. And the chances of a non-bleeding polyp having a cancer is ridiculously low. So it's another discussion. There's no number in the asymptomatic patient that causes me to intervene unless I think they're high risk. You know, they have other factors. But I think that the example I like to give is, so they say 4 millimeters in the ACOG literature. People send to radiology, the machine can measure to 100th of a millimeter. The machine says 3.96 millimeters. Hello, they sleep like a baby. Measures 4.04. Oh, they've got to get a piece of tissue. It's more than 4. Where's the thinking? A woman has diabetes. She has BMI of 38. She measures 3.6. Well, I might want to be more aggressive. You know, she's bleeding. I'm not that happy. I've got a woman who has 2 stents. She's on a drug thinning, a blood thinning medicine for her cardiac stents. She has an episode of bleeding. She measures 4.6. Let's see if she bleeds again. This is called some individualization and judgment. Instead of 3.96, you're okay. 4.04, you're not. Where's the thinking? Where's the individualization? Where's the judgment? This cutoff, especially these dichotomous cutoffs, a single number, and everybody on one side is one thing and everybody on the other side is something else. This makes me crazy.
Well, Steve, I think it's a very good point. So, and I think this is basically what defensive medicine is actually carrying us, and the pitfall of guidelines. So every guideline needs to give a number and a reference, but then this reference is not correctly interpreted as something to guide your judgment, not to drive your judgment in absolute manners. So this is the big mistake. And I think it's probably something that differs a lot in terms of clinical practice, depending on how much you're confident in your expertise. So of course, physicians who are more confident and, you know, experience, of course, it's an important part of practicing medicine. So when you got some white hair, Professor Tian has no white hair, good for him. But I suspect he has a very good expertise anyhow.
Yeah.
But I think that helps a lot. But for younger physicians, it might be more difficult to deviate even slightly. But there's another question from Professor Vallejo, who's actually was actually getting to this point. So what should I do if I have, after menopause, an ultrasound that says that I have a 5 millimeter endometrium? So it was exactly what Steve was saying. So for instance, in Beijing, in China, Professor Tian, so how does these types of guidelines influence the way that physicians react to these borderline values?
Yeah, firstly, we observe the guidelines or consensus from from the American Society of Gynecology and Endocrinology, or the gynecological the OBGYN. Yeah. If the patient just have endometrium larger than 5 millimeters without bleedings, we can observe. We can try to evaluate what's the reasons. We can have some measurements of the hormones. We'll ask the patient whether they have some traditional Chinese medicines without the clear compositions. Yeah, and we will ask whether the patient have some symptoms of the occasionally the ovulation, such as the tenderness or the breast, and 2 weeks later, whether the patient have the bleedings, because it's maybe related. Yeah, if without this clear etiologies, we'll just observe. Yeah, maybe the 1 or 3 months will recheck the ultrasound. But if the patient have the bleedings, yeah, especially irregular bleedings, no matter what's the thickness of the endometrium, will recommend the patients to perform a hysteroscope, especially when the patient have repeated bleedings. Yeah.
I'd like to ask you both a couple of questions that arise by mixing some of the questions, because we're getting to the end of the webinar, so we need to try and address most relevant areas. So there's a couple of questions that refer to how much an atrophic endometrium can be the cause of an abnormal uterine bleeding. And I think this is mostly actually in the question, is more looking at the postmenopausal period, and eventually you might want to comment on how to manage on this. But I think this is also something that is very relevant during the use of, particularly the long-term use of low-dose hormonal contraceptives, particularly in younger patients. We do see some patients with very thin atrophic endometriums who bleed during or particularly with progestin-only pills. That is, of course, quite often the case. So would you like to address that? So is really atrophy of the endometrium a cause of bleeding, or is it overvalued?
I think it's the most common cause of bleeding when there's no anatomic abnormality. In other words, if you look at the literature, I did a review for the Green Journal maybe a decade ago called Modern Evaluation of the Endometrium. And at that time, when I reviewed all the literature, patients with postmenopausal bleeding, the incidence of cancer ranged from 1 to 14%, but most of it was in the range of about 5%. So that means 95% don't have cancer. And I think the most common reason in people who wake up with a stain in their underwear at age 62 is atrophy. Now, whether it's truly endometrial atrophy, whether it may be some vaginal atrophy, occasionally, as Dr. Tian pointed out, sometimes if a patient has it on their underwear, it could be urinary or it could be rectal even. But I do think that atrophy is a source of some of this, not persistent necessarily bleeding, but they have to be worked up. You have to rule out a structural anatomic cause. And then, you know, the real question you're asking, which I've struggled with in spite of my gray hair, white hair, is if you really believe it's from atrophy, how do you treat it? You know, do you have enough gumption to give some estrogen to prevent the atrophy in somebody who now has persistent bleeding, but your workup has been totally negative? And that's tricky.
That's tricky. Yeah, particularly in the set, because it's easier when you're dealing with a woman with hormonal contraceptive. You just remove it and you generally solve the issue. After menopause, that's more tricky. So, Professor Tian, would you consider in a woman who's postmenopausal, she's not receiving any treatment because she doesn't has the need of it because she's not symptomatic or whatever, would you consider starting hormonal replacement therapy to address bleeding, maybe with a combination which is more estrogenic than progestogenic? So is that something that you do any time?
Yeah, that depends on the patient's complaints. Even the patient doesn't have complaints, and it doesn't related to the estrogen deficiency. But if this is special periods of the perimenopause women, when they come in, we usually will try to give an introduction of the MHT. Yeah, not only for the treatment relief or treatment of the menopause symptoms, but we also consider the long term of the bone protections to prevent the prevention of osteoporosis and also the GSM. So usually if we will give the patient the introduction about the MLT, but whether the patient accept the MLT, that's depend on a lot of factors. Yeah, include the ideas about MLTs, the requirements of the woman's health, or the wish, and depend on even the economies of the patient's condition. Yeah, it depends on a lot of factors. Yeah, but we will recommend the patient to consider the MLT.
Perfect. So, I mean, it's been really interesting. I've learned a lot from your comments. Thank you both. And from a number of questions we received, I think it was a very successful set of presentations, and particularly the discussions I liked a lot. So very interesting and clinically oriented questions and answers. So I think it's more or less time to wrap up. Because it's at least in Italy it's 4:30. I suspect that in your countries it's not 4:30 as well. But I'd like to thank you both. It's been a wonderful, wonderful webinar. So I'd like to give back the words to the organizers because I think we have another couple of slides to present. Well, thank you so much. And the first is about the next ISG webinar. Chairman will be Professor Genazzani, our president, and we have two very nice speakers, Professor Błażej Majewski from Poznan in Poland and Professor Alessandro Genazzani from Modena here in Italy. And it's going to be on PCOS and challenges in pathophysiology, diagnosis and treatment. So very relevant and clinically important webinar. And just to close, I'd like to remind you that we're all very eager to get together again in Florence early next year in May 8 to 11. So mark your dates. So get the dates in your agenda because it's going to be another fantastic event as in the tradition of the ISG meetings. So everybody, for gynecological endocrinology, it's a lot of fun. So thank you, Professor Tian. Thank you, Professor Goldstein, for your enthusiastic.
And thank you, Tommaso. You're a great moderator.
I
mean, thank you again.
thank you. But it's really nice. So when I I get fun. So thank you so much. And thank for everybody for listening to us and for posing so many questions. Bye bye and see you next time.
Bye bye. See you.
Bye bye.